I'm not a hepatologist by any means, so I'll be presenting from the primary care perspective. And if you have any questions or things you'd like to add, just chime in. We don't have to wait until the end. Can you guys see my slides?
Looks great.
Okay, great. So today we're talking about hepatocellular carcinoma, HCC, or cancer screening in people living with hepatitis B. Hepatocellular carcinoma is the 6th most common malignancy worldwide, and the 3rd leading cause of cancer-related deaths worldwide. Globally, hepatitis B is the leading cause of this liver cancer. So individuals with chronic hepatitis B can carry up to 20 to 60 times increased risk for getting liver cancer compared to those that don't have hepatitis B. So this is a huge problem for those living with chronic hepatitis B.
Can I add one thing to that? I apologize.
Yeah. No, hop right in.
It is so common, this cancer, that in the hour that we're going to be meeting today, probably approximately 70 people around the world will be dying of liver cancer. So that's how serious this issue is. And unfortunately, while it is a completely curable cancer if caught early, if not caught early, it leads to death. And I'll shut up for a few seconds.
Thank you. It's at 7 per hour. So 7 in this hour. This slide just shows 70. That it's the 70.
70.
Wow. So this is the 3rd leading cause of cancer deaths worldwide, as we can see. And in the United States, it's the 6th leading cause of cancer deaths. So pretty significant still, even without the rates be compared to other countries. It's still a leading cause of cancer here in the United States. So what causes hepatocellular carcinoma? Cirrhosis, so someone with significant fibrosis or liver damage are at an increased risk to develop cancer. But hepatitis B itself is known to cause cancer just because of the way it integrates into the DNA of the host genome. And so this is not the case with hepatitis C. So if you have practice with thinking about cancer in hepatitis C patients, this is a different story. Even if someone doesn't have significant damage to their liver, they're still at risk for developing cancer. Other risk factors that could contribute to someone living with chronic hepatitis B, their risk factor for developing cancer is an older age at the time that they get hepatitis B, heavy alcohol use, and that was defined by more than 60 grams of alcohol per day. Smoking, more than 25 cigarettes per day, was associated with an increased risk. Obesity, diabetes, a family history of liver cancer, exposure to alpha toxin. We don't hear about that much in our country, but in sub-Saharan Africa and Southeast Asia, that can cause an increased risk. High hepatitis B DNA levels, that's on the wrong line there, but just having a high viral load can lead to a higher risk of developing liver cancer. Having E antigen positive status before being converted over to E antibody is an increased risk. Genotype C, the type of hepatitis B, and hepatitis D or hepatitis C co-infection. What protects somebody against getting liver cancer if they're living with hepatitis B? Well, first of all, not getting hepatitis B, so preventing hepatitis B. And then secondly, if you do have chronic hepatitis B, like we just mentioned, converting from E antigen to E antibody, and also sustaining the viral suppression. So decreasing a DNA and hopefully encouraging a transition from E antibody to E antigen.
Katie, so can I add 2 points, Katie?
Yes.
So number one is the hepatitis B vaccine actually was, I think, the first vaccine to show that it is protective against cancer. Because they did a study in Taiwan, and they showed, comparing to historical controls, that once they started vaccinating individuals at birth for against hepatitis B, the incidence of cancer in young people went down dramatically. So you're right. Vaccination is very important towards stopping the spread of liver cancer. The other thing is, there's a lot of evidence that coffee and tea not necessarily caffeinated, but coffee and tea have antioxidants, which may help prevent liver cancer. So, I mean, there isn't a ton of evidence that I make people who don't like coffee or tea to drink coffee and tea. But I do think if you're a coffee drinker, a tea drinker, and you have liver disease, especially, hepatitis B, you probably should be drinking more coffee and tea. I have a fatty liver. I'm at risk for liver cancer because I'm a male over 60. So I used to have 1 cup of coffee a day. Now I have at least 2 cups a day, and I try to have some decaf tea after dinner, hoping to slow down the development of liver cancer. And the last thing I will say about liver cancer is a healthy lifestyle helps to protect against liver cancer. So all the things that people should be doing anyway to live a long life, exercise, keep your weight down, don't smoke, minimal alcohol, those are all things that will help prevent liver cancer as well. So I think from a primary care standpoint, everything that people should be doing anyway to prevent against heart attacks and strokes probably will also help prevent liver cancer.
Thank you. Excellent points. So we want to be surveying or surveillance for liver cancer as early as possible with someone living with chronic hepatitis B. Like Dr. Rothstein said, detecting liver cancer early is the key. And so how do we do that is by looking for it, especially because these 70 people are dying an hour, that there's a pretty poor outcome for those people that do get diagnosed with liver cancer. So screening is sometimes a word used when checking for a disease with no reason to suspect cancer, and surveillance is doing these screenings over and over again. So we talk about liver surveillance. It's this process, often in primary care or in other settings, where we're continually looking for cancer. So this is a study that I found that in 2004 that maybe is responsible for and added to other studies for us adopting this idea of hepatocellular carcinoma surveillance. It was a study in China that looked at 18,000 individuals, and half of them got screening with an ultrasound and AFP, and half of them didn't, and they found cancer earlier and didn't go on to have as many deaths because of this surveillance. It's by no means the only study, but it seems to point to what's helped us develop guidelines for screening for liver cancer. So why don't we effectively catch all liver cancer early? What are the barriers? So the clinician, the primary care clinician, or other non-specialists knowing and identifying the need for this surveillance to be happening, the patient motivation for doing cancer screening, and that goes for any type of cancer. We know that it's hard to have patients go for routine colon cancer screening or breast cancer screening, and patients don't have any symptoms. Like all illnesses, it's hard to prevent and to motivate patients. Sometimes patients are uninsured and there's a high cost to looking for liver cancer. Just timing and scheduling these appointments, other priorities. And then what else? I just wanted to ask people on the call, what else keeps us from effectively screening for liver cancer?
Well, while people are thinking how to answer that, let me chime in on this because this is an area of great interest to me. So first of all, in this country, probably only 10 to 20% of the people who need to be screened are being screened. So, and part of that issue is we know that at a hepatology center, screening is more prevalent than in a GI practice. And in a GI practice, it's more prevalent than in an internal medicine or primary care facility. And, part of the reason for this is, of course, we're just obsessed with liver cancer in our group, but it's a lot of time and effort because this is just not a colon every 5 years or every 10 years, or even a mammogram once a year. This is every 6 months. So it takes a lot of time and effort for both the physicians and the healthcare providers, as well as the patients. And I apologize, you may hear my dog barking in the background, but it is very important it's a team effort. There's no doubt about it. And actually, I met with a young doctor yesterday who's going to help me start a team of young doctors and medical students to help look at all types of all types of cancers, the 5 most common types, and try and identify patients who are falling behind in their screening, and have a team of people calling them up and helping them get their testing done. So it's not just identifying the patient, it's making sure they get their testing done, follow up with them. For the most part, at least in my practice, the lack of insurance or cost is not an issue, but yet still we don't get people getting screened on a regular basis. We did a pilot study at our institution where we bribed patients to get screening. We gave them money if they got screened, and that worked a little bit, but not that significantly. And there's no doubt that I think it would be better if we had ways to do screening that did not involve coming to the hospital. And I envision a time in the future, and I actually did some research on this when I was at Drexel, of a urine screening test that is very easy to do. And maybe in the future, we won't even be doing ultrasounds every 6 months. We'll be doing urine testing every 3 months to look for HCC. But it's a very complicated situation. And I do think we need a brand new way of thinking about how to do this. And I'm trying to prove with this study that I'm doing at Penn, that I'm trying to get off the ground, that current screening prevalence is very low, and that a team approach will hopefully improve this. I mean, potentially double it or triple it or make it close to 100%. And the last thing I'll say is, when I was telling my mother this idea, my mom's 89, lives in Florida in a retirement community. And when I told her that women are not getting mammograms every year, she just had no concept that that could even be possible, because throughout her life, all her friends were getting mammograms every year. But that's not the reality of the situation. I think, and again, I'm not an expert in this area, but I think it's probably only 50% of people are getting mammograms. So that's a whole different situation. But in liver disease, the thought is that 10 to 20% of our patients who need to be screened are being screened adequately. And I'll stop right now.
Catherine, I can't see the chat. Did anybody else share other barriers that they found?
Yeah, we have a lot of really interesting discussion going on in the chat. We had other external barriers like transportation, work, school, childcare, et cetera, lack of knowledge, where to go for testing. I think this is really common too, just like the understanding of hepatitis B as something that needs to be long-term managed, I think is not always understood by some people living with hepatitis B. Absence of care navigation was a really big point, and I think a lot of people also agreed with that. Stigma, fear, mistrust of medical systems also were mentioned as well.
Thank you, everyone.
I would like to add to this that, this is not glamorous, right? The American Heart Association is glamorous. The American Cancer Society is glamorous. Liver disease is stigmatized, and it's not something that is on the forefront. I would love to see more of a national support for identifying liver disease, especially since it is number 6 in this country, and really because travel is much more prevalent. The world has gotten smaller, and people are, integrating into populations. I think that we need to really be the ones shouting from the rooftops to educate our policymakers and our large organizations to be more in the forefront in society, to educate them. They don't know, but without us educating them, they'll never know. They don't know what they don't know. So we need to be bringing rooftops. This is a problem. This is why. It's a bigger deal than most people understand. When I tell patients, hey, I'm going to screen you for Hep B, or hey, I'd like to vaccinate you, and I tell them why, they're surprised at how much no one's ever said this to them before. So thank you, Katie.
Thank you.
Can I make 2 points?
Yeah.
I think one thing we need going forward, and it's been talked about for a long time, but it hasn't really happened, is to try to get some famous people, athletes, Hollywood stars, rock stars, to help do this. So, off the top of my head, I think of Yao Ming and Jeremy Lin, basketball players from Asia. Joel Embiid, Dikembe Mutombo, basketball players from Africa, to get out there and talk about it. I was actually asked by a company that's doing research for a new medication for fatty liver to try and see if I could get Charles Barkley to be their spokesman, who unfortunately has lost so much weight, he probably doesn't have fatty liver anymore. But my friend who knows Charles has lost touch with Charles, and so that sort of reached a dead end. But I do think it may take something like that to get people of fame to be active, do PSAs to help increase awareness and destigmatize the liver disease aspect of things. You may not know this, but in the world of liver disease, they're moving away from fatty liver. They don't want to call it fatty liver anymore. They want to call it steatotic liver disease and metabolic liver disease, and because they think that fatty liver is stigmatizing. I personally don't feel that way. I have a fatty liver and I'm fat, and so I need to deal with my fat, and maybe my fatty liver will go away. But the medical community is actively changing the word fatty liver, and we probably will not be using that sometime in the near future. I still have a ICD-10 code that says fatty liver, so until they take that away, I will still be using that. And the one other thing I wanted to add is, Katie, I looked at your numbers, and you said that there are 880,000 deaths from cancer a year. So I did the math, and it's 95 patients an hour are dying of liver cancer.
Wow.
So it's worse than what I told you at the beginning of the meeting.
Almost 100.
Yeah.
So how do we screen for hepatocellular carcinoma? The cornerstone is using ultrasound, as most people might know on this call, but if you don't, that's usually what's acceptable right now, and that does require making an appointment and going to a hospital for the most part. It's the cornerstone. It has a sensitivity of 60 to 80% and a specificity of greater than 90% for detecting hepatocellular carcinoma. It has been determined that every 6 months is the ideal time to do an ultrasound because of the doubling time of a small tumor, I suppose. This ultrasound interpretation can be difficult because it's operator dependent. So if you have someone that knows what they're doing, you might get a better reading than if you don't. If someone has a fatty liver or obesity or nodular cirrhosis, it could be even more difficult to use an ultrasound to detect early hepatocellular carcinoma. A 1 centimeter size threshold is used to determine whether a lesion is considered potentially positive. Other types of radiographic surveillance are CT and MRI. They both can have false positives, so they're both not recommended as an initial screening tool. CT also has the negative radiation exposure, especially if you're going to be doing this every 6 months. So neither of them are recommended as initial screening tests, but both can be used to follow up on a positive result from an ultrasound, a lesion greater than 1 centimeter.
Katie, can I make 2 points about these
Yes.
slides? So the first point is, there was a study from Europe where they looked at patients who underwent liver transplant. Some were known to have cancer, some were not. And when you take a liver out, it goes down to pathology, and they do 1 centimeter cuts through the liver to look for cancers. And what they found was very disturbing. Number one, ultrasound missed half the cancers that they found at pathology.
Wow.
But to me, what's even more disturbing is CAT scan and MRIs missed 1/3 of the cancers. So our current technology is missing a very large number of cancers there. Now, if I had my way, I would do an MRI in every single patient every 6 months, but that cost is astronomical. And what's being done around the country is we really don't need the entire MRI to be done once we know someone has cirrhosis. What we really need is the 15-minute study that looks at the liver with no contrast, the arterial phase, and then the venous phase, because that's when you pick up the cancers. So that only takes about 15 minutes. So the goal is to show that if you do an MRI in 15 minutes, it means you can do 4 MRIs in an hour, which means maybe we can lower the cost to the cost of an ultrasound, because the only reason why we're not doing MRIs is the cost is really astronomical compared to an ultrasound. But once they're at the same level of cost, everybody will be doing MRIs. So that's the goal that we have going forward. And I'm hoping that that information will come out soon. I know at Penn, Dr. Rosen has been doing that. I don't know where he is in his research, but I do think in the future, we will easily be doing MRIs every 6 months because the cost will be the same as the ultrasound is today.
Dr. Rothstein, how do you order that? Can you order that specific now?
No, you
That's
can't.
specific.
Right
Okay.
now, they don't do it, but they're doing a study to it. There
Right.
are studies
Okay.
going around the country, and I think once those studies come out, I think everyone will start doing it, and it will really improve. And the last thing I want to tell you is, I would tell you at least once or twice a year, I run into a patient who gets their ultrasounds, gets their alpha fetoprotein done on a regular basis, and still presents with terminal HCC. Will tell me, I don't understand. I did everything I was told to do, and yet here you're telling me I'm dying of liver cancer. And my only thing I have to tell them is that ultrasounds don't pick up everything. Alpha fetoprotein doesn't pick up everything. But it is very disheartening to see that happen. And unfortunately, it happens almost every year. And if it's happening to me, it must be happening to everybody around the country as well.
Thank you. So in addition to radiographic surveillance, we can use serum biomarkers. As we mentioned, AFP is the most widely used biomarker right now. From what I know, 20 can be used as a cutoff. I'm not sure if other people want to chime in about a cutoff, but on its own, an AFP isn't ideal to look for liver cancer. It really needs to be with an ultrasound, and it also can be maybe useful when there's changes in AFP. So if you're doing an AFP every 6 months, despite the actual number, it really depends on how much change there's been.
Well, I just want to say 2 things. Number one is, when I see an AFP above 100, my radar goes off that something is very bad. And I'll do an MRI or a CAT scan. And if that's negative, I go to the other imaging technique, because there are clear studies showing that you may miss a cancer on an MRI, but it shows up on a CAT scan and vice versa. The other thing that I'm very concerned about is a rising AFP. So many years ago, I had a patient with an AFP of 10. MRI didn't show anything. And for some reason, they got an alpha fetoprotein 3 months later. It was 40. We did another MRI, and lo and behold, he had 2 cancers. So a rising AFP, even below 100, has me concerned. You do get low level elevations when people have elevated liver enzymes. It's a sign of hepatic regeneration. And the last comment would be that 20% of cancers in the liver do not produce AFP. So a normal AFP is helpful, but you can't rest on just a normal AFP. You still have to do imaging.
Right. So other serum biomarkers that are maybe in use in other countries or under study are DCP, which is widely used in Japan for looking for liver cancer, not really used in the United States yet. The GALAD model, which I know we've talked about in this ECHO group before, is a combination of gender, age, AFP L3% and regular AFP, and then DCP, and that together might increase sensitivity and specificity without doing radiographic testing. And then so there's some studies or some investigations, I'm sure, for lots of other ways of screening, like Dr. Rothstein mentioned, maybe with a urine. What I read about was this liquid biopsy, a novel assay to identify circulating tumor cells in the blood that would, be able to detect early cancer. Is there anyone else that wants to comment, or Dr. Rothstein, do you have anything else to add about investigational serum biomarkers that might be available?
I will comment on this. The GLAD model is highly touted by my boss. He helped design it, Jorge Marrero. I have not really started using it on a regular basis, but I'm being cajoled by him and a couple of other hepatologists to start using it. I'm pretty happy with my detection rate for early HCC. So what I've been doing has been working. The only problem is when patients don't get their imaging or don't get their labs done. I recently had a patient who had an elevated AFP. It went from 6 to 14. I drew an AFP L3%, and it was significantly elevated, more so than the alpha fetoprotein. And then it turned out that we do think he's got a recurrent HCC. So I'm leaning towards using the AFP L3 as well when there's a slightly elevated AFP. And I do think this liquid biopsy is going to be the wave of the future. I think we're going to have blood testing that's going to, put AFP and all these other things to shame. And if they're good enough, we could probably do away with the imaging and don't do any imaging until the liquid biopsy is positive. But still, in my opinion, still investigational and not ready for prime time. I don't know if other parts of the world are using this already.
Thanks. So what do the guidelines recommend? The AASLD guidelines recommend that all adults with cirrhosis of any etiology, so whether it's from hepatitis B, hepatitis C, or other liver disease, should be screened for hepatocellular carcinoma. In addition, Black men older than 40 years of age, Asian men older than 40 years of age, and Asian females older than 50 years of age, those are folks living with chronic hepatitis B, should be screened regardless of if they have cirrhosis or not. If a patient living with chronic hep B has a first-degree family member with a history of liver cancer, they should be screened, and any persons with hepatitis D. And the recommendation, as we've already mentioned, is ultrasound every 6 months with or without AFP. I'll briefly go through these other.
Katie, can we go back to that for 1 second? Because I want to rip it to shreds. I don't like this at all. I think it kills people. If you follow this, I think you're killing people. So number one, I do think that in other parts of the world, they do not want to screen patients with severely decompensated liver disease for HCC because it's not going to change anything. But here in this country, if you develop a tumor, it can get you to the top of the list and get you a liver. So we continue to screen our patients with severe decompensation. I don't like this age limit at all. And while it may not be cost effective to screen younger individuals who are surface antigen positive, I've had a fair number of patients in my career in their teens, 20s, early 30s who have died from terminal HCC because nobody was screening them. So for me personally, when I see a patient who's surface antigen positive, I start screening them. I don't know if everybody else does that, but that's just what I do. So I do think, I could tell you right off the top of my head, I've had 3 Asian females. One was at 19. The other one was 32. I had a young gentleman from Africa who died at 19. These were all people with Hep B who were not being screened. And by the time they presented, they had advanced stage 4 liver cancer and were terminal. So whether it's cost effective or not, it may not be, but I do think that for me, my job is to make sure my patients don't die of liver cancer. So I don't think the cost of an ultrasound and an AFP every 6 months is astronomical. especially when you can save a couple of lives. So that's just my feeling. I don't know how other people feel about that.
Absolutely. I screen all my patients with chronic Hep B, regardless of age or race, partly because of the high rate of other comorbid liver problems in my practice, HIV, hepatitis C, alcohol use. So it's just easier for me as well, just to have everyone with chronic Hep B be recommended for screening.
Katie, could I make a comment as well regarding HIV, people with HIV specifically and Hep B co-infection? None of the society or regional guidelines have any threshold to screen related to HIV for as a risk factor, but we do see that people with HIV, we know HIV is pro-fibrotic, we know with the proto-oncogenic virus, then it's certainly at risk of HCC, and with our work in different observational cohorts, saying that any degree of Hep B viremia increases the risk of HCC in our people with HIV. There are data out there to suggest that. I know Dr. Rothstein has accurately identified that the putting these thresholds of age really can still exclude a number of people at risk for HCC. But I throw in here as well from that any person with HIV who's 40 or older certainly needs HCC screening, and if they have a Hep B co-infection, but with the caveats of particularly identifying additional risk factors, age at Hep B acquisition, first degree relatives, things along those lines certainly need to have that discussion. But even in people on treatment for hepatitis B, that risk in people with HIV, that risk for HCC still persists. And we still are not really great at capturing all those patients who need that screening. So at least within the cohort of people living with HIV, really thinking about HCC screening and everybody 40 and older with Hep B co-infection, I think is critical as a threshold or a barometer for a starting point.
A great point. Thank you.
And
Catherine, did you want to add something?
Yeah, just to also just emphasize a bit Dr. Rothstein's point, I think if we look at the epidemiology of HCC, particularly within the African community, we are seeing rates of HCC among a really younger population in the mid-30s to even lower than that on average, particularly West Africa. I think the data is really limited as well, but I just want to flag this as well. And I also think that they're in progress of updating guidelines, so I hope to see a bit more information coming out about screening that includes, more comprehensive screening and a lot of these factors that we've all mentioned just now in this conversation.
Thank you. So as they are, the AASLD guidelines recommend if there's a lesion found more than a centimeter that they should go on to diagnostic imaging with a CT or MRI. If it's a lesion seen but not greater than a centimeter, then they should have a repeated ultrasound and AFP maybe less than 6 months from the time of the initial exam. I put in the other boards recommendations. They're all honestly about the same. So EASL, same, all persons with cirrhosis, except if they're decompensated. We talked about that a little bit. They also suggest maybe doing some scoring systems, which we don't really use here yet, but REACH-B, GAG, HCC. I'm not sure what all those scoring systems involve, but it would seem to make sense if someone has a high viral load or something else going on that they would be more at risk. Those might be being used in other countries, but not really here. The Asian Pacific Liver Board is similar. It just states that persons without cirrhosis and screening depends on the incident and cost effectiveness. In some Asian countries, the recommendations could vary for each country. And there's a primary care work group that is online to talk about hepatocellular carcinoma, and they have a very similar recommendation as the AASLD. Nothing really to note. So all these guidelines are similar, but I think we have a consensus that they're all inadequate to really address sufficient screening for liver cancer. And so we need to continue to, I guess, push for those guidelines to be changed. As was mentioned, prognosis of hepatocellular carcinoma is not good. 5-year survival rate once diagnosed is in the United States is approximately 20%, and survival really depends on being diagnosed early. So how do we do that? We screen more, which we've been talking about. We screen earlier and we screen often. I just wanted to end with some conversation around practical tips for integrating hepatocellular carcinoma screening in primary care. We've mentioned some of these. For me personally, one thing I've done is make a separate diagnosis for screening, because sometimes if someone has hepatitis C and it's treated, or hepatitis B and it's being treated, they don't often think of liver cancer screening in that same problem as a clinician. So I like to add another problem to the list of problems so that we can continually remember that the ultrasounds and AFPs need to be done. At our clinic, we use AmeriCorps volunteers or care coordinators. That's the name of the position here. They really do a lot of the legwork for colon cancer and breast cancer screening, checking those UDS measures that we get paid to do for primary care. So incorporating that staff into liver cancer screening has been really effective because they understand how to reach out to patients, how to set up the screening test, how to remind patients of their tests, and also developing a relationship with one hospital. So we use Temple a lot. So if someone is going to go for their ultrasound and they call from there saying that they don't know where they're going, they don't know what hospital they're at, they don't have their script with them, we kind of have a relationship where a couple of our staff members know how to get the faxes over quickly. I'm sure some of you that work in a hospital system is a little bit easier, but for us as an outpatient primary care clinic, to make that bridge with an inpatient staff has been really helpful. And then I just put down this question mark about possibly someday being able to do ultrasounds in the office. I know this is a lot of dependent on the quality of the ultrasound and then the operator, because that's really a trained skill to be effective at looking for liver cancer with a sonographer. Any other comments and questions?
I have a couple of comments. Number one is, I think in other parts of the world, hepatologists and gastroenterologists will basically do ultrasounds in their office, which, we do ultrasounds in our office primarily to do staging of fibrosis, look for fatty liver, and if we're going to do a paracentesis. But I personally don't think I'm trained enough currently to be doing ultrasounds looking for liver cancer, and probably my radiology division would not be very happy for me if I did that. But the other thing I wanted to say is, going back to prognosis, early on in my career in the 80s, no one was really looking for liver cancer. And so the 6-month survival was 5%. And now when you think about it, 5-year survival, I think you said, was 20%. But it's clear to me that with the advent of transplant, with early detection, we are basically taking a disease that was once incurable and terminal, and we're getting 80% 5-year survival with liver cancer with the availability of transplant. So again, and we can do other things. We can resect it, we can radiate it. There are other chemotherapies. Interventional radiology can burn the cancer, inject alcohol. There's many different treatments. So I think, we should be getting 5-year survivals way above 20%, and primarily incorporating liver transplant. But again, it gets back to what we said at the beginning. You got to find the cancer first in order to improve survival, and you have to find the patients that need to be screened. And that's something that we are trying to do, not only in Pennsylvania, but across the country. We do want to eradicate hepatitis B and C by the year 2030. And part of that, in my opinion, is identifying these patients, treating them, curing them with Hep C, controlling them with Hep B. But even so, those patients will need lifelong surveillance for liver cancer.
Absolutely.
Dr. Rothstein, I sort of to tailor or tangent onto that comment. I wonder if there is a role for in-office ultrasound or point of care ultrasound for at least the initial evaluation. We see that so many people are in need of HCC screening and either would overwhelm our radiology colleagues in the local radiology departments if everyone actually came in for that ultrasound screening every 6 months. I wonder if there's, in addition to these thresholds for screening, the page B score, things like that, to potentially identify those who can defer screening for X amount of time. Are you aware of any data to suggest that point of care ultrasound or in-office ultrasound could be used as an adjunct to screening, or identify those who may need more formal imaging modalities, whether it be MRI or CT, that could arguably be implemented more routinely in a an office setting?
Well, I don't think here in the US we have evidence, but I do know in other parts of the world, the hepatologist sees the patient every 6 months and does an ultrasound. So my guess is that they're having better detection rates than we do, because the patient, here it's an extra step. You see me in the office and then you have to go for your ultrasound. But along those same lines, we are so overwhelmed with patients now that I'm being asked not to see my stable Hep B patients more than every 12 months, and in some cases every 24 months, and to do everything electronically or over the phone. And one of the things I'm going to do is I'm going to get 1 or 2 volunteers to help me track these patients so they don't fall away and basically leave my practice without me knowing. Obviously, if they come back every 6 months, I keep on top of things. But if I don't see them for a few years, they don't. But I will say this, at least with Hep B, I think I've noticed in the last month or two, I've had 3 or 4 patients who I haven't seen in 4 years, but they get their labs and they get their ultrasound every 6 months, and like clockwork, and they've been very compliant, which has been great. But that's, there are a lot of patients that just kind of disappear from my practice. And I have one patient in general, he had Hep C. He had cirrhosis, he was getting MRIs, now fetal proteins every 6 months for 3 years after he got cured of his Hep C. And then he said, why am I doing this? I'm cured, blah, blah, blah. 2 years later, he's having liver pain. I do an MRI, he's got a liver mass. I stage him, he's got 2 masses in his lungs, and he was gone in 3 months. And again, guy's working full time, he's got a house at the shore, and just a unnecessary death, in my opinion.
We do have a comment in the chat box that I wanted to flag for everybody. And this is directed to Dr. Rothstein, but I'm sure others can comment on it. Are you in favor of recently published Chinese guidelines recommending treatment for patients greater than 30 years old with any viremia? They also recommend all patients receive ultrasound and AFP every 6 months, and those with higher risk of HCC every 3 to 6 months.
Well, I'll be happy to answer that. I do think that I'd like to see the evidence that that is the correct thing to do, but quite honestly, I would lean towards doing that. I think it would make things easier, because the decision on who to treat and who not to treat, it's very complicated, and people have a difference of opinion. So I don't know if we'll ever get the proof that treating everyone with viremia is the right thing to do. I do think there's evidence out there that screening every 3 months for cancer with the current technology that we have is no better than every 6 months. And there have been studies looking at that. But that's with the technology that we have now, which really hasn't changed in a long time. I mean, those studies were ultrasound and alpha fetoprotein. So I haven't seen, I think with the newer treatments, the newer technology, liquid biopsy, other markers, or maybe better imaging techniques like the shortened MRI, maybe we'll find out that for high risk patients, every 3 months is the way to go. But currently, I have not seen any evidence that that's better than 6 months.
Thanks. Anyone else have any comments on that one? A question?
I was wondering the same thing, basically, and just wanted to clarify, what is the ongoing rationale for not treating those with viremia who have a normal ALT, AST? Because I feel like this is very similar to the early guidelines of not treating people with HIV who had a viral load less than 350. And then, over the years, they realized that for that person's long-term overall health, it was ideal to treat HIV as soon as it was identified?
I think it comes down to a cost measure because for the immunotolerant patient, even though I think they have a slightly higher risk of developing liver cancer and a slightly higher risk of developing cirrhosis, it's not that much greater than those patients who are without viremia. And so it's going to be a lot of time, effort, and money to treat all those patients. Now, clearly, with elevated liver enzymes, high DNA levels, it's a different situation. But I could just tell you my own personal experience with my immunotolerant patients. And again, it's a small number of patients. It's maybe 20-year follow-up. They've all done very well without any treatment. So I think it's still a controversial area, but I do think the trend and the momentum is towards treating everybody who has some viremia, and I think that's what we'll be doing in the future, despite the cost and despite the fact that you may be submitting someone to 40 years of treatment for no clear benefit. But I think that's where we'll be in a year or two.
And I will say this is like the global debate right now in terms of the new guideline development. We had conversations about this with the WHO guideline development committee in May, and the new guidelines should be coming out in October. But the cost was certainly an issue, as Dr. Rothstein said. I think the lack of data for hepatitis B specifically is not necessarily there for a treat all approach. And our stance at the Hep B Foundation, at least, is why treat after damage? And if a person wants to be treated but doesn't meet the guidelines, why not offer them treatment? Where's the harm, kind of thing? But really, it's kind of a risk benefit analysis, and kind of should be individual kind of basis where we kind of are standing at that point. But I think that we'll start to see more and more movement towards treating all approach, similar to like the HIV model. But yeah, really great questions. Any other thoughts, Dr. Torgerson or Dr. Nguyen, on those issues?
I wonder, my approaches for engaging patients for their HCC screening is similar to addressing all the comments that people have mentioned thus far. I wonder, are there other strategies that people are using to try and engage patients? When I have patients in my clinic, I'll say, let's call radiology now, get you scheduled. You don't have transportation. You're trying to really address those barriers. Are there, and I like the idea of having sort of this checklist or an additional diagnosis to help sort of flag the need to screen those. Are there other tools or strategies patients or providers have used to remember that this HCC screening is needed and critical?
It's really hard, Dr. Torgerson. I've found that I work very closely with my case manager, who I think I'm going to ask that she gets invited to these calls, because she'll learn a lot from this. I rely on her heavily, and I meet with her and two other staffers we go over the list of patients who are living with Hep B, as I do with my other diseases, whether it's HIV, Hep C, Hep B, or my PrEP patients. I do it monthly. Each of them get a week dedicated to them. So I meet once a week with the staff, and I go over the list of names, and we look at who came in recently, who's had labs, who hasn't, when was their last ultrasound. But that's really manpower heavy, and I guess I can still do that here at this level with a small number of patients. That's not going to translate well to an organization that has hundreds, thousands of patients, right? And even then, I don't get through all of those names. But I do try to spend as much time as possible putting a lot more onus on the patient. And I do so by helping them understand how we don't see this as a grave disease as much in this country, but helping them to understand that globally, this is a big deal, and that it can progress to very lethal standards. And I'm very clear about that. I show them images, I use models and say, this is what a healthy liver looks like, but this is what can happen. trying not to be a Debbie Downer when I talk to them. But I feel that if you are very clear with patients, that perhaps it will increase their adherence.
Yeah, that person power and patient engagement, it sounds like it's critical. Unfortunately, the staffing issue is often the variable that we have less control of. Fantastic.
I just want to add from a patient perspective that there's a lot of patient motivation is really key, and I think you guys mentioned patients who are co-infected with HIV, HCV, but they also for myself, just for myself, speaking for myself, I have other comorbidities. So I have to get every 6 months, I have to make an appointment with my hepatologist, get an ultrasound, get blood work, and just for my Hep B. But then I have an autoimmune disease, and I have to get screening and surveillance for all that. And then, for example, in April, and then I have to get my mammogram, whatever, for my screening for breast cancer. So, for example, just in April, I had an ultrasound for my liver, I had an ultrasound mammogram for screening for breast cancer, and then I had a bone density scan. So that's a lot of scanning and screening for your typical patient. So I think anything you can do to help with case management, I think that would be very, very helpful for the patient.
For patient navigation, with to
Yeah,
help
absolutely.
organize.
Mm-hmm.
And Melissa, I wonder if you could maybe speak to, the surveillance that you've experienced maybe over time, and like what has motivated you to keep going back to that regular surveillance. Because I think that we find that a lot of times people may do it for a short period of time and then disappear from the health system, for example. So anything that any insights you might be able to provide might be helpful, I think.
Yes, so I actually was diagnosed when I was about 30, and I went to my screening, went to see a primary care, internal medicine doctor for a couple years for screening. And then I was in graduate school, I was busy, and then I just kind of let it slide. But then in my 50s, one of my friends died of liver cirrhosis, not related to hepatitis B. And that was a wake-up call for me, saying, hey, I need to take care of my liver and go back to screening for my Hep B and HCC.
Thank you. Yeah, that's helpful. So,
and then I think just to tack onto what Dr. Rothstein was saying about spokespeople, I think that's huge, because I used to work in the pharmaceutical industry, and every single disease has a famous spokesperson that patients can relate to, and I think that's a huge motivator for the patient.
yeah.
Glamorous.
Yeah. Hepatitis B, we've certainly struggled in the space
Right.
of finding that person and getting people on board, I think, because it's not as like sexy as other things. And we also don't have funding. So there's a lot of challenges for that, but I think it's something that we keep talking about. And I think it's important to have these conversations. But this was an amazing discussion today. I hope everybody found it as valuable as I did. I appreciate Dr. Nguyen and Dr. Rothstein for taking the lead on guiding us through this conversation, and certainly our panel of attendees and also experts to kind of weigh in on some of these key topics, which are really global issues of discussion now in terms of guideline creation and development. So as those guidelines do come out, we'll be sure to continue these conversations and figure out how we can implement those guidelines on the ground here in Philly and beyond, because I know we're not all in Philadelphia. Any last minute comments from anyone or questions? We'll definitely skip the case today because we're at time pretty much.
I just want to say how much I look forward to this every month, because this is, supportive of what we do as clinicians, and it's certainly extremely informative. I learn every time, and I just appreciate all the expertise and personal experiences you guys bring to the table. Thank you. And congratulations, Dr. Nguyen.
Thank you.
So happy.
I agree. I look forward to this time as well. So thank you for everyone for being on the call.
Yeah, thanks everyone. Echo that. I always enjoy it as well. We always have a lot of really great discussion and conversation, which is very invigorating, I think. Yeah. Awesome. We couldn't do it without you guys. Awesome. Well, thanks everyone for joining us. We hope to see you guys in September For our next session, fourth Thursday of the month in September, we'll send out information on that. We'll bring our case into that conversation next month. But if you do have a case that you want to share, if you have a patient that you have a lot of questions about or want some clarification on, or just a general Hep B case that you see in your practice, let me know and we can send you the case form and you can present a case for next month. And with that, I will conclude our session. We'll follow up with notes and information on today, and want to just thank everybody again for being here. Thanks to our speakers as well, and look forward to seeing you next month.
Take care.
Thank you.
Thank you.
Take care.
so much.
Bye-bye.